So now I am for this afternoon and early evening. My topic is going to be periimplantitis, and my idea is that I will divide it into starting with some more heavy stuff, so to speak. We will initiate talking on the pathogenesis of periimplantitis. And then we will move into and discuss a little bit on diagnosis and prevalence of periimplantitis. After that, the idea is to discuss risk factors, who are the patients that are more prone to develop this, and are there any specific individuals that we think are in risk for periimplantitis. And then ending up a little bit later on discussing non-surgical therapies on periimplantitis and peri-implant mucositis, and then finally ending up with surgical procedures. This is sort of the schedule. So, okay, I will just give you some background. I think Per did so. I work in Kristianstad, but I also has a professorship in Dublin and in actually one of those technology institutes in Sweden as well. And where I'm located, you see here, this is of course the south of Sweden. And if we enlarge it a little bit, so Malmö is here, and Copenhagen is over here. Here is where I flew out from yesterday. And this is the area where I do work. This is now the scheme of my presentation, as you can see. And as Per mentioned, we just last year finished this book on periimplantitis. My very good friend Jean-Louis Jovenoli, who's a French guy from Paris, he and I have worked with this project for a very long time. I think we started to discuss periimplantitis very early, when basically it was non-existing. Everything went just fine. There were no problems. And if you were told that there is a problem around the implants, it was certainly not periimplantitis. One reason why we know so little, I think we need to go back a little bit in history and see that really we have not been using implants for such a long time. You see in this picture that in 1965, the first patient in Sweden were treated with the so-called Brånemark implants. And in that time, this was a very specific procedure. The patients were very selected. They were almost, investigated also by medical professionals before they were allowed to put any implants within them. And in 1974, the implants were said not to be recommended in dental practice in the United States. And first in 1986, which is not so long ago, they were really allowed and accepted and introduced in the US. And about 1986, it was the time when I started to place implants myself. And of course, at that time in Sweden, it was Brånemark implants or the Nobel implants that we used. So now you all know that the survival rate of implants is said to be in the range of 95% or so. And this is true, and it is really, I think we need to have this picture from the beginning, because otherwise you will maybe feel that I'm negative to implant therapy, and this is not the case. I think implant therapy is very good. However, I would also like us not to forget that problems can arise. So if you have 95% of the implants where you have a survival rate, you have still 5% that are lost. And if we look at the literature, we know this is over about a 10-year period or so. But this guy that I operated maybe 25 years ago or so, he is going to keep those implants maybe for 50 years. So, I mean, the time that really long time survival rates we have, 10 years, it's not a very long time for us. So really, what is happening over time? This is a study recently published by Bjarne Petterson and co-workers, and he did a systematic review on the survival and complication rates of implant-supported fixed dental prostheses after a mean observation period of at least 5 years. So at least 5 years. He found and analyzed 32 studies, and the survival rates of the implant supporting fixed dental prostheses over 10 years was 93%. So this is what we said before. It's very good. But he also reports that 44% of the patients, they had complications within a period of 5 years, sorry. So complications on implant therapy is a very common problem. And what are the complications? Well, we have, of course, the mechanical complications, the fracture of veneering material. In 13.5% of the cases, we can find this. We also find that we have loss of access hole restoration. This is in 5.4% of the cases. This happens. And all those things makes that the patient has to come to the dental clinic again. And another complication is, of course, that we have abutment screw loosening and that we have loss of the retention of the cemented prosthesis. So those are common complications, mechanical complications. These are not the ones we are going to discuss today. So, but I just want to highlight that, you know, on top of what we are going to discuss today on the biological complications, we also have a lot of the mechanical complications on our implant patients. So this picture I just put in there to give us some perspective. I mean, what type of implants are we going to use? I mean, if we really think that the implants we are putting in our patients, they are going to stay there maybe for 40 years. It will be of importance that we can get spare parts. So it is important, in my mind, that we have a possibility to obtain spare parts to the implants that we need to repair. So moving on into the pathogenesis of the biological complications. Biological complications is also common, as we will discuss later on. If you look at this clinical slide from a tooth and from an implant where we still have the keratinized mucosa, they look quite similar, but as you can see from the schematic drawing in the middle, they are completely different clinical situations. Because where you have the tooth, you have the sharpest fibers, you have the collagen fibers inserting into the tooth, into the root surface, and this way also creating another space between the epithelial and the attachment on the bone level. In this side here, you will have a longer junctional epithelium to the implant surface, and we will not have, of course, no soft tissue attachment to the metal surface. Then we will have the osseointegration further down. So those are two completely different situations, and we will look later on what they may relate to when it comes to the clinical situation, but also to the histological situation. One common, not common, but one possible, biological complication after the implant has osseointegrated in the bone is that you will lose osseointegration around the whole circumference of the implant due to overload. And this was shown by Flemming Isidor in the early 90s, and he demonstrated in this study that if there was overload to implants in the monkey, he would end up with a soft tissue alignment around the complete implant like this. Of course, you understand that these type of implants are not treatable. This means that even if we, adjust the occlusal forces, now we have broken the osseointegration, now we have a soft tissue around the implant, and this implant has no retention in the jaw at all. Clinically, it may look like this. This is a case where you can see one small thick implant and one a little bit longer, thinner implant. And you can see this little thing here. And I would like you just to keep your eyes on that, because then we put the superstructure in place. We have this in the same place. And then now you can see that we have no osseointegration around this implant. But the height of the bone is the same in all the three pictures, which means that when you overload an implant, you will still keep the height of the bone. You will not lose the height. You will not find any craters or anything like that. You will just have a split between the implant and the bone. And this implant, if it had not been connected to the bridge, of course, you could just put it out by pliers or anything like that. So this is the situation where you have overload, but this is the situation when you have a periimplantitis. With periimplantitis, you lose the marginal bone, but you still have osseointegration in the apical part of the implant. So if you put those on side by side, in the upper, this is a situation where you develop periimplantitis, where you lose the marginal bone. You get these type of crater-shaped defects, while in the lower two pictures, you can see that you will keep the marginal bone, but you will lose the osseointegration around the full circumference of the implant. And those are two completely different clinical situations, and they need completely different handling from a clinical point of view. In my mind, the latter one, or this one with overload, is not a very common complication. You see them quite rarely, but the other one we see very frequently, of course, since a lot of the referrals we have to our clinic are periimplantitis cases. So why do we develop periimplantitis? Here you can see one of the major reasons. Just as with natural teeth, if plaque is allowed to accumulate on the surface, you will get an inflammatory response. And in the early days, it was thought that the microorganisms were not so prone on colonizing the implant surface as they were on colonizing, for example, an ordinary tooth. This is not the fact. The colonization is virtually similar to what we can see on teeth. And this was demonstrated very nicely in this study, which is basically something done in the same or similar way as the old study on experimental gingivitis. So this is the experimental peri-implant mucositis. What they did in this study was that they had 20 partially edentulous patients. They put and had implants in the posterior edentulous areas. And after the suprastructure was placed, then they had supervised professional care for 2 months, and then the patients were told to refrain from oral hygiene methods at all during a period of 3 weeks. Very similar to the old studies on experimental gingivitis. And what happened is that there is no difference between teeth and implants regarding plaque index. So they have the same amount of plaque. There's no difference when it comes to the bleeding index. So if it bleeds around the teeth, it also bleeds around the implants. And there is no difference in the sulcus bleeding index either. So this is one of the studies that are behind, this consensus that were taken at the 6th European Workshop of Periodontology in 2008. And it was concluded that if there is a biofilm on the surface of the implant, it will lead to the development of mucositis, peri-implant mucositis. It was also concluded that the flora on the implants are similar to the one that we can see on chronic periodontitis patients. And this is, in my mind, very important for us as clinicians, that periodontal pathogens, they may transmit from teeth to implants, which means that it is very important that in the patients where we are putting implants, that they are periodontally healthy. They need to be periodontally healthy before we put the implants in, if we are going to increase, the success rate with our therapy. So all periodontitis should be treated before we put the implants in. I think this is very important. If we look more closely to the pathogens around implants, I said that they are similar to the ones with chronic periodontitis, and of course then we can find the ones that we see in periodontal cases. We will see, of course, Prevotella intermedia, Porphyromonas gingivalis, Tannerella forsythia. We will see Fusobacterium spirochetes, Actinobacillus, and so forth. But we will also find something that I, in this slide, have called others. And by others, I have highlighted a few. We will also find, in many cases, Staphylococci. We will find Candida, and we will find Enterobacteria around implants. This has not been reported so frequently around teeth, but if we look, we will find them even there. But this is something I think is very important. Also, we can see that very shortly after we have placed implants in the mouth of the patients, these implants will be colonized by the microorganisms. We will have microbial colonization within actually 30 minutes or so after installation, and this has been shown in several studies that this is really what we can find. We can also see that there is a slight difference between how and what type of bacteria that are colonizing the implants as compared to the teeth. And as I mentioned before, one of the types of bacteria we find is the Staphylococcus aureus. And if we look at Staphylococci, Staphylococci has a very high affinity for artificial surfaces. And it's not only seen, around dental implants. It's also frequently seen around medical devices where you get infection. Staphylococci is often one of the microorganisms that we can locate. Staphylococci, they form a very thick biofilm on the surface of the implant, and it has the tendency to inhibit the recruitment of PMN cells to this area, so we have less inflammation in that case, which is favoring the infection because now the host cannot really take care of the problem as well as they should. And it has been reported to be present in around 65% of peri-implant cases where microbial data is collected and where we have looked for this bacteria, because not all types of studies have looked for Staphylococci, but in those ones where this is looked after, about 65% of the cases we will find this bacteria. So it's a common one that we can find. And we just recently published a paper. It has been now online, where we looked at, if there is a specific cluster of bacteria that really is associated with periimplantitis. To do this, we looked at microbial samples from quite a big number of periimplantitis patients, 166 ones. And we compared that to 47 individuals that had what we considered healthy implants, which meant that they were not bleeding and so forth. And in each of the patients, we used one implant per patient. And the status was defined based on both clinical and radiographic data. And then we used the DNA checkerboard hybridization method to analyze presence of, I think it was 78 different species. So we had two panels for DNA checkerboard analysis in all these individuals. And out of all those 78 different bacteria, we found that there were 7 bacterial species that really defined that there was a difference between the implant status. One of them, and the most prominent one, this gray one is the bacterial load for the selected species. You see the bacterial load is much higher in the periimplantitis than in the implant healthy ones. And the one that sticks out is Tannerella forsythia. We have P. gingivalis, Streptococcus mitis and intermedius, Staph aureus, anaerobius, and Tannerella sokransky. Those are the ones that differentiate the implant status when you try to compare between all those individuals. And if we now make an analysis and adjust for age and, when we adjust for gender and smoking status, we see that one thing that differs health from disease is older age. So the patients with periimplantitis are older. We also see that they have more of Tannerella forsythia. And we see a second one here, that the ones that have a previous history of periodontitis are more within the group of periimplantitis. So those are the 3 things in this study that we could see different between healthy patients and periimplantitis patients. It's the age, presence of periodontitis previously, and also presence of T. forsythia. So if we now look on another schematic drawing, just to get an idea how the lesion looks around implants and teeth, this is trying to mimic that. So around teeth, you can see that the infectious lesion depicted here is, about something like 0.7 to 1 millimeter from the bone level. It's so-called encapsulated. It doesn't go all the way down to the bone. You still have insertion of the Sharpei fiber into the root surface. While if we look at this one that is trying to depict what we see in the periimplantitis cases, you can see that the disease goes all the way down to the bone level. And I will show this a little bit later on. But this is basically the differences between, the diseases around teeth and implants. Around teeth, it is encapsulated. Around implants, it goes all the way down to the bone level.